go ahead and get started. These are my disclosures, and I don't think there's anything there that would interfere with my giving the presentation today. And also, just full disclosure, a lot of my slides are from the actual meetings, and so just be aware of that. All right, I'm going to start out with a slide on the prostate cancer treatment landscape. This is probably very familiar to a lot of you nowadays, but basically what this is all the treatment options for the various disease states of prostate cancer as you go from left to right, localized disease to metastatic disease, and as you go from castration-sensitive disease to castration-resistant disease. And so hopefully I'm not missing anything there, but this should be up to date as of this year. And hopefully this will serve a sort of a slide of reference as we kind of go through the rest of the presentation. So this was a pretty tall order for me to kind of go through everything prostate cancer related from ASCO and ASCO 2024. And I actually, believe it or not, tried to do that initially. And then I found out at slide 200 I had too many things to talk about, and so I tried to narrow this down. And so first of all, apologies if I don't talk about your favorite presentation or some sort of science that you were involved in, but I had to limit this. So the way I've organized my talk today is basically in 3 sections, and I'm going to try to go through 6 trials that were sort of the larger phase 2-3 reports that we saw from the various 2 meetings, and then also 2 presentations on novel therapeutics and 2.5 sort of presentations on biomarkers and correlatives. And so the first 3 presentations I'm going to be going over are actually all from ASCO, and so we're going to jump right into BRCAAway. BRCAAway was a randomized phase 2 trial of abiraterone, olaparib, and the combination of abiraterone and olaparib in patients with metastatic CRPC bearing HRR mutations. And so this was presented at ASCO by Dr. Ahmad Hussain, and just kind of looking at the study design and patient baseline characteristics here. There were 3 arms to the part of the trial that she presented. Arm 1 again, as you can see there, and 2 and 3. For these 3 arms, basically patients with BRCA1, 2, or ATM mutations were enrolled, and they were randomized 1:1:1 to those 3 arms. And as you can see, basically when they progressed on arm 1 or arm 2, they were given the option of discontinuing and going and crossing over to the other medication. So like, for example, if they were on abiraterone, they progressed, went over to olaparib, and vice versa. If you were on arm 3 on the combination arm, if they progressed, you were off protocol. And the key eligibility included first-line patients or patients receiving first-line therapy in a metastatic CRPC setting. There was no allowed prior PARP inhibitor, AR pathway inhibitor, or chemotherapy for metastatic CRPC. All the patients had a BRCA1 or 2 or ATM alteration as defined by NGS. Primary endpoint was progression-free survival by various criteria there. Secondary endpoints included measurable disease response, PSA response, and toxicity. So if you look at the baseline characteristics on the right-hand side there, as you can note, first of all, this was a small trial. There were about 20 patients in each arm, 1, 2, and 3. Also, if you kind of look through the characteristics, about 57 to 84% of the patients had bone mets. About anywhere from 11 to 33% of the patients had visceral mets. Patients had either germline or somatic genetic alterations. Most of the patients had BRCA2 mutations ranging anywhere from 68 to 90%, and there was certainly a imbalance in the arms, as you can see. So, and again, notably, I would just point out that crossover was allowed. All right, so this was the primary endpoint of PFS. And as you can see here, going across the top row there, median PFS for arm 1 was 8.4 months. The median PFS for arm 2, 14, and in arm 3, the combination was 39. And you can also see the objective response rates there, as well as a PSA response and undetectable PSA response rate. And the Kaplan-Meier curve for PFS is shown right below, certainly showing a pretty nice split for the patients getting the combination arm. This was a slide that Dr. Chi kind of put together, which I really thought was informative. And so this basically included the PFS results in terms of the crossover patients. So as you can see, the patients in arm 1 who crossed over from Abi to olaparib were 8. So certainly not a lot, certainly not half. And for arm 2, the crossover patients included 8 as well. And if you look at the median PFS on the crossover sort of experience, 8.3 months after the arm 1 patients crossed over to olaparib, 7.2 months for the patients who crossed over, vice versa. And then what's nicely put there is also the sort of median PFS from randomization, 16 months for arm 1 crossover and 16 months for the patients who crossed over in arm 2. And then if you kind of look at the red arrows there, the arm 3 patients who got both medications in combination right from the get-go actually had, again, a median PFS of 39 months, which is, as he kind of pointed out there, you cannot directly compare these results, but on the other hand, the results are very intriguing. Okay, and here's the PFS swimmer plots, kind of demonstrated the same thing. In the blue, going over to the orange there, are the patients in arm 1 crossing over to olaparib in orange, and then in the middle sort of area, the patients in arm 2 on olaparib crossing over to abiraterone, and arm 3 in purple, the combination, and it definitely seems to suggest that the combination arm did better in terms of PFS. And this is even more intriguing in the context of a couple of notable things. Like, for example, less than half of the patients crossed over on the trials, and also more importantly, that from our real-world data, we know that a lot of patients don't receive more than 1 line of therapy for metastatic CRPC. So in conclusion and takeaways here, patients with metastatic CRPC and BRCA1 or 2 or ATM mutations, abiraterone and olaparib were well tolerated, resulted in better PFS and response in abiraterone and olaparib alone. While the number of crossover patients were small, the combination had better PFS compared to sequential therapy. Combination of abiraterone and olaparib had already received FDA approval back in May of 2023 following the PROPEL study results. And despite the limitations from this trial having small numbers and by the trial design, considering that many of the patients do not get more than 1 line of therapy for metastatic CRPC from real-world data, this trial supports and strengthens the use of the combination of ARPI and PARP inhibitors in the first-line metastatic CRPC setting, particularly for BRCA1 and 2 mutated patients. All right, jumping right into the second study here, this was the CONTACT-02 study, and this was cabozantinib and atezolizumab, which is a PD-L1 inhibitor. Cabozantinib is a TKI, versus second novel hormonal therapy in patients with metastatic CRPC. And this was an interim sort of result presentation done by Dr. Agarwal. So this is the study design here, and as you can see, metastatic CRPC patients who have progressed on 1 line of NHT or novel hormonal therapy, and also had measurable extrapelvic soft tissue metastases were enrolled on this trial. And the reason for that and why that's important is because cabozantinib in the COMET-1 trial showed basically a RPFS and OS sort of benefit in subgroup analysis on the COMET-1 trial, and the combination basically also showed clinical activity and also acceptable safety profile in the COSMIC-02 1 trial. And so these patients on this trial on CONTACT-02 were randomized to 1-to-1 to either receiving the combination of cabozantinib and atezolizumab, which are novel agents in this for prostate cancer, and then versus second-line NHT, which a lot of the presenters at both of the conferences this year sort of called ARPI switch, which is really important. We know that ARPI switch doesn't really yield great results, and there was a call to question about whether or not that was actually a valid control arm. But either way, that was a control arm in this trial. The trial included dual primary endpoints of PFS in the ITT population per RECIST 1.1, and also OS in the ITT population as well. Secondary endpoints included response by RECIST 1.1, and there was a stratification of those with liver mets and those previously treated with docetaxel, and as well as the disease stage for which the first NHT was given. So here's a patient disposition here on the left-hand side. 855 patients were screened, and then out of those patients, only 507 were randomized, so there was basically a 40% screen failure on this trial. And then basically in both of the arms, there were about 250 patients who were randomized into either arm. And looking at the baseline characteristics of the patients, these patients had pretty advanced disease. So as you can see there, more than 50% of the patients had Gleason 8 or higher at diagnosis. Basically about 80% of the patients had bone mets, about 40% of the patients had visceral mets, and about a quarter of the patients had liver mets. About a quarter of the patients had prior docetaxel for CSPC, and many of the patients had already had first-line NHT at either one of those indications there. Okay, so this is the PFS primary endpoint for the study in terms of the ITT population, and as you can see there, the curves are split. The median PFS for the cabo-atezo arm treated patients was 6.3 months. For the second-line NHT or ARPI switch control arm was 4.2 months. There was an absolute difference of only about 2.1 months, and the hazard ratio was 0.65. So this was considered a positive trial because of those results, and also notable because it was the sort of a first for an immunotherapy combination in metastatic CRPC. And looking at the OS sort of results, just kind of threw that on there because it's an interim sort of presentation, but basically it doesn't look very exciting there. All right, so looking at the pre-specified subgroups, as I kind of talked about, so the liver mets population, the hazard ratio was notably a little bit better, 0.43, and there was a wider split. For the docetaxel previously treated patients and also the bone mets patients, there was a little bit of a split as well in terms of PFS. And in terms of treatment emergent AEs, basically, as you might imagine, the combination arm had more grade 3, 4 treatment emergent AEs, 48%. There was also 33% treatment-related AEs as well, and some of the more common grade 3, 4 AEs included diarrhea, fatigue, anemia, and hypertension. And in terms of subsequent therapy, here are the results from that. Basically, only about 19% of the patients from the combination arm went on to receive further chemotherapy, 28% in the ARPI switch arm went on to receive further chemotherapy. And I think those numbers are pretty low, but what's also notably important here is that just in general, many of the study patients did not receive subsequent therapy. So CONTACT-2 conclusions and takeaways in a heavily pretreated CRPC patient population for its features. Cabo and atezo showed a significant PFS benefit compared to ARPI switch. There was improved PFS with novel agents in pre-specified subgroups, including those with liver mets, prior docetaxel, and bone mets, and this finding was notable. However, in terms of real-world applicability, I think that's a little bit more limited. 40% screen fails is kind of concerning for how applicable it is. Also, as well as the PFS benefit of only being about 2 months, which is pretty modest. And as Dr. Chi pointed out, that's basically not even one scan interval's worth of time. And also, the overall survival results are kind of immature. ARPI switch as a control arm is kind of questionable. And we know also that from the adverse event profile that the combination is not necessarily easy to tolerate, which makes it more of a question as why would you not do chemotherapy for these patients? So. All right, moving on to the last GU ASCO presentation I'm going to talk about. This was the EMBARK study, and I think for those of you who were here at the breakfast presentation, I think Dr. Gervaisi probably beat me to the punch here, but just kind of go over this really quickly. In this study, basically, this is actually a publication that was already presented or published in New England Journal of Medicine back in last fall, and then subsequently the FDA gave a label extension to enzalutamide in November of last year. So this was not a new presentation in terms of results at GU ASCO, but it's notable. So in this study, if you're not already familiar with this is a 3-arm study, a phase 3 study, that looked at people with high risk biochemical recurrence who basically were randomized to either a combination enzalutamide plus leuprolide or enzalutamide by itself, or let me go back here. Wheel, okay, thank you. For this study, this presentation specifically, this was given, I think, by Dr. Neil Shore. He was mainly focusing on the enzalutamide monotherapy treated patients. So this is the study schema, which you can find online now and also from New England Journal. This is a pretty unique sort of design. So patients with high risk non-metastatic CSPC with rising PSA after local therapy. These were patients who were staged by conventional imaging, not PSMA PET imaging, who also had a PSA doubling time of 9 months or less, and CSPC were randomized 1:1 into the combination of enzalutamide with leuprolide or enzalutamide by itself, or leuprolide with placebo. And then pertinent for this presentation, those of the patients who actually achieved a really low PSA of specifically less than 0.2 after 36 weeks of therapy were also allowed to suspend therapy or go on a drug holiday. And then there were criteria to reinitiate therapy if the PSA rose, depending on if they were treated with primarily with prostatectomy or radiation. The primary endpoint on the study was mets-free survival of enzalutamide plus ADT versus leuprolide alone. Secondary endpoints were mets-free survival of enzalutamide versus ADT alone, time to PSA progression, time to new therapy, and OS. And of course, the patients who did not suspend therapy, did not achieve a really low PSA, they were to remain on therapy. So this is from the New England Journal article. After a median follow-up of 60 months, you can see that mets-free survival, the Kaplan-Meier curves there were pretty nicely split and split relatively early. The median MPFS was not really reached in either arm. And I believe, I thought I had I guess at the 60-month mark, the 87.3% of the combination patients were still alive and without mets, and 71% of the patients who were treated with just leuprolide alone at the 60-month mark were still alive and without mets. And on the right-hand side, you can see the MFS results for the enzalutamide monotherapy treated arm versus ADT. Overall survival was not yet mature, but here are the results. It definitely looks like it's favoring enzalutamide, but the results are still early. So moving on to Dr. Shore's presentation, the patients who suspended therapy, this is their breakdown. So out of the patients who were on enzalutamide versus ADT, there were 90.9% of the patients who were able to suspend therapy in the combination versus 67.8%. And in enzalutamide monotherapy treated patients, there were basically about 85.9% of those patients. In terms of the duration of treatment suspension, which is also different here as well, the combination treated patients, they were able to be on a treatment-free holiday for about 20.2 months on average, as opposed to 16.8 for the leuprolide treated patients and 11.1 months for the monotherapy arm, enzalutamide monotherapy arm. So in terms of the patient characteristics, of course, this was not a randomized part of the trial, so not expecting the numbers necessarily to be equal, but basically for the suspension, treatment suspension patients on the sort of first two columns there, enzalutamide monotherapy, for those patients, there were about 304 patients. For leuprolide treated patients, there were about 240 patients. And if you kind of skip down to sort of the last couple of columns there, in terms of primary definitive therapy, basically these were relatively well balanced. About a quarter of the patients had primary radical prostatectomy, another quarter or so had about primary radiation therapy, and about half the patients actually had prostatectomy and radiation before. All right, so for the patients who were not able to, this is out of order, okay. Okay, so for the patients who were able to reach treatment suspension and looking at mets-free survival, as you can see there, for the enzalutamide versus ADT comparison, there was pretty much no split. 5-year MFS rate for the enzalutamide monotherapy treated patients was 80%, as opposed to 77.9, and the hazard ratio was 0.84. For the patients who were not able to undergo treatment suspension, there was a much bigger difference there, favoring the enzalutamide monotherapy arm as opposed to leuprolide-treated patients. The 5-year MFS rate for enzalutamide-treated patients was 82.6%, as opposed to 55.3%, favoring enzalutamide monotherapy, and the hazard ratio was 0.34. So in patients who had no treatment suspension, MFS was better in those treated with enzalutamide monotherapy. All right, so this, I think, is a nice table that kind of answers a question that might come up in clinic, which is that, what are the proportion of patients who remain with undetectable PSA at 2 years after treatment suspension? So the numbers are pretty low there, but you can see that basically they're relatively similar, with only about 14 patients in the enzalutamide monotherapy treated patients and 23 of the leuprolide treated patients, equaling 4.6% and 9.6%. So at 2 years suspension, the proportion of patients having an undetectable PSA were similar. Okay, this is also really important as well, the adverse event profile, which was different for enzalutamide versus ADT. I think has already been talked about, but basically the enzalutamide-treated patients had a lot more fatigue, gynecomastia, arthralgia, nipple pain, breast tenderness, as opposed to the leuprolide-treated patients had more hot flashes and hypertension. So in summary, basically I believe this is a practice-changing sort of presentation, although it wasn't primarily discussed or presented at GU ASCO. But in the essence of time, I'm going to try to skip on ahead here. So this was the MAST study. This was a randomized double-blind placebo-controlled trial of metformin in reducing progression among men in expectant management for low-risk prostate cancer. Metformin, there's been a lot of interest in using this as an anti-cancer therapy, and the reasons are, for example, are that it does show potentially some anti-cancer effect, it's low cost, it's well tolerated. There's also a lot of interest in trying to repurpose medications for cancer therapy. However, the data quality is pretty poor. And so what this study was trying to do was trying to have a study with a homogeneous cohort of prostate cancer patients undergoing active surveillance with hard endpoints based off of serial biopsy. So this is the study schema, and patients with low-risk prostate cancer, and included basically NCCN very low-risk and low-risk cases with Gleason score of 6 or less, and also less than 1 or equal to 1 to 3 cores involved, or less than 50% of any one core being positive, were randomized 1-to-1 to either active surveillance plus placebo versus active surveillance plus metformin. And the primary endpoints were looking at progression, time to progression. They also included the breakdown of progression into pathologic progression versus time to therapeutic progression. And the patients were subjective to specimen and data collection through the trial. So I'm gonna quickly kind of skip on through this one. As you can see, there is really no difference in the primary endpoint of progression-free survival. And in terms of trying to go back and look at what happened for the patients on this trial and the progressed patients, they looked at patients who had a BMI of less than 30 or greater than equal to 30. And surprisingly, there was actually a detriment in terms of PFS probability with the metformin-treated patients who had a higher BMI. Also, another sort of surprising and unexpected and unfortunate sort of finding was that the patients who progressed, there was a higher likelihood of having Gleason 8 or higher disease for the metformin-treated patients. So this is the toxicity data. In short, there was just more toxicity with metformin in terms of GI toxicity and also weight loss. And so the key takeaway points here are that metformin does not prevent progression of low-risk prostate cancer, suitable for active surveillance, and also the exploratory subgroup analyses indicate a potential detriment for the patients with high BMI and also at time of progression going towards Gleason 8 or higher disease. All right, so CHAARTED2 and also the next one is CYCLONE2. I'm gonna kind of skip through these relatively quickly. I threw these up here mainly because they were phase 2 sort of larger trials, but the CHAARTED trial was looking at cabazitaxel and abiraterone for first-line treated CRPC patients. Here is the study schema, and here is the sort of primary endpoint here of PFS. OS was actually not, the study was not powered for, but they actually met their PFS endpoint. The median PFS of the cabazitaxel abiraterone-treated patients was 14.9 months. In the abiraterone-treated arm, basically it was only 9.9 months. Hazard ratio was 0.73. Overall survival, again, not powered for, but showed no difference there. And so in conclusion, basically, while this study was able to show that the combination of abiraterone and cabazitaxel prolonged PFS, but basically there was no OS benefit, and also because the treatment landscape had evolved beyond sort of the treatment options that were included on this trial, the real-world applicability is sort of limited there, mainly because in the metastatic CSPC setting nowadays, we're using ARPIs and we're already using doublets and triplets. CYCLONE2, I think I'm almost out of time here, so I'm going to kind of skip through here. It was a negative study, and do I have any more time? Can you summarize the last study? Well, all right. These are probably too difficult to talk about, but basically, J&J 6420 was a human kallikrein-2 targeted monoclonal antibody that was conjugated to a radionuclide, actinium-225. And so this was a novel agent with a new mechanism of action. Human kallikrein-2 is sort of related to PSA. PSA is human kallikrein-3, but it's notable because it exists in not only a secreted form, but also uniquely it's also got a membrane-associated form. And so they did this study, which was a sort of a phase 1 study, and they had to adjust the format of the study quite a bit, mainly because of toxicities of thrombocytopenia and interstitial lung disease. So I'm going to skip through this, but basically they did show in a heavily pretreated population of patients, there was actually pretty nice activity, as you can see there. And even after one dose of the medication, they were able to get pretty durable dose responses. And ARV-766, I'm just going to go over this one really quick. This is a PROTAC androgen receptor degrader for MCRPC that was presented in a phase 1/2 study result presentation. And this was a AR degrader that targets the androgen, the wild-type androgen receptor, and also the androgen receptor ligand-binding mutations of ARL702H, H875Y, and also T878A, which are clinically relevant. It binds to the ligand-binding domain, and it ends up where the androgen receptor is degraded. So novel therapy, and here is the best PSA decline in patients with the mutations. As you can see here, there was pretty notable PSA 50 and PSA 30 responses. And so in conclusion, they were able to show that ARV-766 was well tolerated. The AR degrader showed promising clinical activity, including in patients with ligand-binding domain mutations, and that it warrants further development in advanced prostate cancer. So I think I'll stop there. Thank you very much.